So my name is Ian Humphreys. I'm the rhinology fellow, and I'd like to speak to you about endoscopic management of anterior skull-based tumors. My intention tonight is not specifically to talk about malignancies, but rather direct a set of principles that apply to any neoplasm, whether it's benign or malignant, as it relates to the anterior skull base. I'm going to spend some time going over the idea of surgical innovation as it relates to rhinology, show some few representative example cases, and spend most of the time on outcomes and how it relates to the management of these tumors from a historical perspective as well as contemporary management. So these are some of the things that we'll go over tonight. And I'd like to start with kind of a historical perspective, and that endoscopic surgery, always attracts controversy. And this is a picture of Professor Messerklinger in 1980, who's really credited for the idea and innovation of using and repurposing the endoscope for its use in sinus surgery. And when he first discussed the ideas of using this for sinus surgery, this was very progressive, and at the time, sinus surgery was really being driven by the open approach with headlights, nasal speculums, in a transnasal fashion. And using an endoscope was really progressive for that time, and so that it did attract controversy. And with experience and time in writing, he was able to push the envelope in terms of using the endoscope for sinus surgery. Then we moved more towards more aggressive procedures, and that first evolved into CSF leaks, pituitary surgery, and then, as we're going to talk about tonight, the idea of using endoscopes for tumors. So that brings us to this kind of concept of surgical innovation, or innovation in general. This here is called a Rogers curve, and this curve was developed actually for agricultural purposes out of Iowa State University. And it was the idea of using hybrid seeds for a particular corn. And when the researchers looked at the adoption of using hybrid seeds for agriculture, they found that there was these various 5 categories in the spectrum of utilizing these products. And those that were considered innovators were in typical large commercialized diversified farms, whereas those that were considered laggards, and I'll define that in a moment, they found were usually small, single crop, low income, and poorly educated farmers. And so the idea of this curve is that in any one given moment in time, the adoption of a surgical technology, over history, we can see the pattern of the distribution of when that innovative idea is introduced, and particularly for an individual. So for a corollary in sinus surgery, if we think about the idea of the endoscope, and as it relates to any surgical procedure of the nose and sinuses, if today someone was adopting the use of an endoscope today for chronic rhinosinusitis or sinus surgery, I think that most would consider that individual a laggard, and that it's behind the proverbial curve, that has been adopted and proven, it's been vetted through research and time and experience, to be shown to be used as a useful tool in the contemporary management of these patients. However, CSF leak has been newer in the evolution of the use of the endoscope, and that in the moment today, the utilization of endoscopes for CSF leak repairs, we may consider that a late majority, that the first wave of the innovation technology for endoscopes was in the realm of sinus and inflammatory disease, and we moved into CSF leaks as it relates to the anterior skull base. Pituitary tumors came later. We would consider that now an early majority, that major centers across the United States have adopted the use of endoscopic technology for pituitary approaches. It certainly doesn't mean that it's used exclusively. However, many pituitary cases are currently performed with the endoscopic pathway. So what about the idea of tumors and neoplasms? And if we think in terms of malignancy, I would say that today we're in the realm of innovation to early adopters. That those centers or those surgeons that are using endoscopic technology for the purposes of a oncologic resection of a skull-based tumor are in the realm of early adopters. Developing experience, the research is immature, the ideas and patient selection are still evolving, and it turns out that this whole process takes approximately 25 years. And if we think about our initial kind of setting up this whole conversation with Dr. Messerklinger, he introduced it in the 1980s. We're currently now approximately 35 years later. So we're following in suit with this idea of this curve of 25 years. So what we know from this is that lasting change happens incrementally, that each step of the way scientific validation is required, and the scientific literature is really key in that process. And it really holds us in this important role discerning what is fad and what actually becomes a meaningful, durable innovation in surgery. So now let's talk a little bit about the evaluation of patients with skull-based tumors. I don't intend to go over the nuances of the day-to-day clinical care, the endoscopy findings of skull-based neoplasms, but I'd rather like to highlight areas of controversy, clinical decision-making, and things that we use in the evaluation of our patients. I would think that most of us in this room would believe that CT and MRI are considered complementary. CT defines the bony anatomy, MRI is delineate the soft tissues to help us understand dura, neurovascular structures, and then we'll touch about the idea of PET. So we're going to spend more time on MRI and PET. And when we think about MRI, one of the critical roles of MRI in skull-based tumors is really a critical appraisal of the dura. We do know from research that dural involvement is an important predictor of ultimate oncologic outcome in terms of survival, whether it's 5-year or disease-free survival. In this study, this was a study from Pete Batra at the University of Texas Southwestern. This was 50 patients that were prospectively evaluated. They all had histologically proven tumors. 37 of them were malignant, 13 of them were benign. And they wanted to really fully assess the dural margins as a key prognostic indicator. So 12 of these were confirmed histologically to have dural involvement. And in this table here that you see off to the side, I want to highlight 3 areas that are delineated in the red boxes. This first one right here is the idea of nodular dural enhancement. We can see that those that have nodular dural enhancement, all of them had histologic proven evidence of dural involvement. So the sensitivity for this finding, although it's a limited patient population, a small sample size, was very high. However, if we look at the specificity, it's much less. The idea of linear dural enhancement has classically been taught as a finding found in skull-based tumors as a highly sensitive or potentially predictor of dural involvement. However, in these data, we see that this was not only poorly sensitive, but also poorly specific. Hypointense zone was a newer concept, and this is the transition between the dura and the cranium. And I'll show a representative picture of that here in a moment. But what I want to highlight is in those that have absence of the hypointense zone, nearly all of them had dural involvement. Whereas those that had the hypointense zone, none of them had dural involvement. The last one is the idea of dural thickening, and it's separated in 1 millimeter and 2 millimeters. Those patients that had greater than 2 millimeters, again, all had dural involvement. However, the sensitivity was less robust. So what we've taken away from this is the idea of a hypointense zone, dural thickening, and nodular enhancement. Here's a representative picture of what that looks like. So this is a T1 MRI. This is showing in a coronal view. The red chevrons show where the dura is here, through the anterior skull base, dura. And then the blue arrow is pointing to the obvious cytonasal pathology that we see here. So the areas that we're looking for is the idea of nodular dural enhancement, which is represented here. And this is the hypointense zone, and that's what the red chevrons are trying to draw your attention to. That's this space, this black hypointense space between the dura and the next bony structure. Here, we've lost the hypointense zone. We have nodular enhancement, and it's greater than 2 millimeters. Again, variable sensitivities and specificities, but it highlights some of the more recent developments in terms of MRI findings for these tumors. What about the idea of PET scanning? Who do we get PET scans on? Why do we get PET scans on them? Is it useful? What does it tell us? This was a study by Vijay Ramakrishnan out of the University of Colorado who looked at 51 patients. They were all biopsy-proven cancers of the sinonasal passageways. There were various histologies, and what they found was that the tumor site in those patients that had PET scans, it was 94% sensitive and a false negative rate of 6%. But in terms of the distant metastasis, they found that only 31% had evidence of distant metastasis. And so they tried to figure out, well, which of those patients had distant metastasis, and therefore the PET scan would be of higher utility as of those who didn't have distant metastasis. The only trend that came out in multivariate analysis was high SUV and advanced T stage. I'll show the data here. So here, if you look at the odds ratio for the higher of SUV, there's not a significant trend represented by the p-value. Advanced tumor stage shows a higher odds ratio, but still didn't reach statistical significance. So what do we take away from this? And the limitation is that it was a smaller sample size, variable histologies, various T stages, and various treatment ultimate algorithms. So we may see a trend with histology, but it's not entirely clear from these data. So what does this leave us with? Well, in the evaluation of these patients, certainly critical to this is a multidisciplinary approach. We here have a multidisciplinary skull-based conference that includes these various subspecialties, as well as a tumor board, and it ultimately derives into a collaborative, supportive, and equitable team environment. The treatment options for these patients are thought of in various ways. We know that, power. No, my computer's fine. It's something on the podium. So we know that these tumors are rare, and that poses a problem for the literature. There's no clearly defined protocol as of this moment, and the body of literature is not mature, and we're going to revisit this concept here in a little bit. So when we think about and we talk tonight about the treatment options as well as the outcomes, it's in the context and framework of these limitations. The data sets are retrospective, with low levels of evidence, heterogeneity of tumor types, and that's in reference to histology. We have different comparisons. Some patients have an open or the idea of an en bloc procedure versus piecemeal resection. Whether it's single modality versus multimodality, they receive adjuvant therapy, they receive post-operative treatments. And then the ultimate outcomes that we measure are different, whether it's survival, whether it's quality of life, recurrence, complications. And these are some of the areas that we find particularly in all of head and neck oncology and oncology in general, but really in the skull-based literature. So the surgical treatments can be classified in various ways. Single modality versus multimodality, the idea of en bloc, extradural versus intradural, and then the ultimate surgical approach. So let's talk a little bit about the idea of single modality versus multimodality. I apologize that the table is a bit small here, but what I want to highlight is these three areas. In this series of 223 patients, and this was a German series, they had a total of 223 patients from 1967 to 2003, and their follow-up time was 10 years. 32% of these patients had surgeries in isolated modality, 47% multimodality, and 20% had radiation chemo alone. In the group that had radiation and chemo alone, the survival rate was 12% at 5 years, and it dropped to it was approximately 20% at 5 years, 26% survival. And those patients that had surgery only, 51% survival at 5 years. At 10 years, it was 36%. And those that received surgery plus post-operative RT, 50% to 30%. So what I want to set the framework here in the stage is that our survival is in the order of around 50% of those patients that have surgery as an incorporated part of their treatment plan. Historically, the idea of en bloc versus piecemeal has attracted controversy. This was the University of Iowa experience. This was from Drs. Funk and Hoffman, who published their series from 1985 to 96. This was 30 patients. 16 on en bloc, 14 went piecemeal. And the traditional approach and thought and concept was that in cytonasal cancers or skull-based tumors, you couldn't achieve an en bloc, or you had to achieve an en bloc resection, and that piecemeal resection, or vis-a-vis the endoscope and its piecemeal resection, was going to be compromising oncologic outcomes. So in this series, again, only 30 patients. This was histologic all-comers. This included squames, adenos, esthesios, melanomas. We see the idea of en bloc at 1 year survival is 94% versus 56% at 3 years. And a piecemeal resection, meaning endoscopic, was 83% and 70%. So we see in some range an equivalency here. However, some of these were hybrid procedures, and that's one of the caveats to this paper. The extensive resection, whether it's extradural or intradural, matters. So the idea of intradural resections, these were the anterior craniofacial resection, whether it's external, the endoscopic one, or whether it was a hybrid technique. I'm going to show a few representative examples of each one of these. So this first one that I'll show you is a piecemeal resection. This is an extradural adenocarcinoma. So here on the left side, you'll see a coronal CT scan a radio-opacified, radio-dense mass here filling the entire right nasal cavity. There's a question here of a defect in the skull base right along the lateral lamella in the anterior group fossa. The lamina appears to be intact and the septum grossly appears to be intact, but we're worried about this area right here. Here's what it looks like on gross physical exam in the clinic setting. Obviously a fleshy appearing mass that's exophytic and seen with sessile in the right nasal cavity. So here's a picture of the resection of this tumor. So this is with a 0-degree endoscope. This is using a microdebrider shaver at this point. We're initially debulking a tumor. This is now taking the middle turban up to its attachment on the lateral nasal wall. These are the first steps are to debulk the tumor. This is now along the middle turban and into the anterior ethmoid skull base. Over here is septum. This is where middle turbinate was. Now we're dissecting along the skull base, taking a curette and identifying and looking for what we believe is the nidus or sentinel attachment of this tumor to the skull base. Taking a suction curette now along the skull base, septum's over here. This is now the olfactory groove. Now moving along the ethmoid skull base, continue to debulk and remove mucosa. And now we're at the level of the skull base, and we're drilling some of the skull base away. And what you'll see here in just a moment is that we've identified this area that we saw in this CAT scan that looked as if there was bony erosion, and there it is, and that's dura. So we're going to take a dural resection. So this is now using angled telescopes, as well as a dural knife here to resect a specimen in a dural margin. The dural margin right here is being removed. You can see a low flow CSF leak, which is very typical of the anterior cranial fossa. Dura is being removed now with cup forceps. Again, low flow CSF leak, you see pulsations. You can see brain now up through this area. You've got a wide surgical field. Now we're going to raise a nasal septal flap on the patient's right side. The right septum was not involved with the tumor. This is making the anterior cut of the incision. And now we're going to raise the nasal septal flap and redrape it over that area for the skull base defect. The skull base defects can be repaired in many different ways. This is a pedicled septal flap. This is a nice option because it provides a pedicle vascularized tissue to this space. This is placed in a piece of the septum from the vomer up into a multi-layered reconstruction. So that's extradural, intracranial in place, and now the nasal septal flap covering the defect site. So again, we thought this was an extradural tumor. This was an adenocarcinoma, one of the more common cancers of the sinonasal passageways. And this was repaired with a multi-layered reconstruction. What if we know that it's intradural? So here's an example of a melanoma. So on the right here, you'll see, or your left rather, you'll see a coronal CT scan. We have this large neoplasm obliterating the left nasal cavity. Again, we see some areas of skull base attenuation or diminution. The maxillary sinus has air in it. This we suspect is likely post-obstructive secretions. We look here at the MRI. This is a T1 coronal with gadolinium. We see clearly this kind of heterogeneous appearing mass filling the left nasal cavity with post-obstructive secretions in the maxillary sinus. And then, what do we see in the dura? And so right here on the dura, we see evidence of dural thickening. We lose the hypotensome, and perhaps you could say it's nodular, but there certainly is thickening there at the dura as well. So here's how we approach this one endoscopically. So again, this is the patient's left side. We're using a 0-degree endoscope. This is the septum right here. This is debulking a tumor. That's always our first step, is to debulk the tumor. We're always keeping out our eye and our mind for the site of attachment. This is now along the orbit, so this is the lamina precaria. We know this is a melanoma, so we're going to resect all the mucosa in this area. So this is dissecting with a suction curette along the lamina precaria to remove that down to the periorbis. Certainly, if the periorbit looks suspicious, you can take periorbital margins or biopsies as well, depending on the extent of the tumor. This tumor appeared to be more along the skull base. This is just removing the final partitions along the orbit. Periorbit appears to be grossly uninvolved. This is now following the tumor along the skull base. This is septum here. This will be out lateral over here. This is angled telescopes using a suction curette along the skull base, removing the mucosa down to the bony or anterior cranial fossa, and now drilling down the bone. We know that we believed on our imaging that we had gross dural involvement, so we're going to make sure that we get into that space. This is refining that area around what we suspect is the nidus of attachment or the origination of this tumor. We're beginning to see that the bone is becoming very thin. You can see a faint hue here of dura, and that'll become more evident here in just a moment. So, angled telescopes with drills. Now you can see the pulsations. Here's dura. Maybe have gone through dura a little bit right here, exposing brain. We have a low flow CSF leak. Again, very common for the anterior cranial fossa. Using the drill into that area. Now we're resecting dura. So we're taking a wide rim around what we suspect is the involvement of dura. So So this is a magnified view. This is probably approximately a centimeter of dura. You can see now brain and pulsations and CSF coming down through. Here's our defect. This is now going to be closed in a multi-layered fascia. So this is a fascial graft that's being put in place, tensor fascia lata. Along here's our final dural defect after margins were retained and the resection has been performed. So this is an intradural inlay. This is now the nasal septal flap, which we've seen previously. It's just showing it on the inside. The last surgical approach that we'll talk about is the idea of an anterior craniofacial resection. This has been the gold standard for sinonasal and skull-based tumors. It has been traditionally done in an external fashion. It has a 34% major complication rate and a 5% mortality. And it is the idea of an en-bloc resection. In 2001, Roy Castellano at the University of Miami popularized and described the idea of a total endoscopic anterior craniofacial resection. He argued that it improved visualization with cosmesis, they had decreased major and minor complications, there was less blood loss, there was less hospital time, and overall patients preferred. The question was, did it provide equivalent or even superior oncologic outcomes? And that's yet to be seen. So the anterior craniofacial resection is an area of ongoing refinement and research. The absolute contraindications to this are orbital extension, necessitating an exoneration. Recurrent tumor, those that go up and over the orbit, just it's a physical access. You fulcrum on the orbit, you're able to reach that space. If there's anterior soft tissue involved in a tumor, and those that spread beyond the maxillary sinus, but I would argue that is relative depending on what approach you decide to take. With angled telescopes, you'd be able to reach some of these areas. So these relative contraindications are becoming more relative, as with large intracranial extension, depending on the surgical experience, the instrumentation that you have. These are on a case-by-case basis. Palatal involvement, and then tumors within the PPF and infratemporal fossa. Again, I think that depends on the approach that you're taking and your skill set and your experience in these areas. So you can use this approach for benign tumors as well, and one of these would be a meningioma or also a dermoid. And I'm going to show you an example of meningioma because I think it's a nice, clean, representative example of how you can approach this space, whether it's a malignancy or a benign tumor. It shows the anatomy and the idea of the approach very cleanly. So this is an olfactory group meningioma. Here's our T1 MR showing the tumor, and it's completely filling the anterior cranial fossa. So the first step for this patient, because it's a benign tumor, is we're going to go ahead and raise our upfront nasoseptal flap. We're on the right side of the nose, lateral nasal wall. This is now resecting the middle turbinate up at this attachment to the lateral nasal wall. You can see the nasoseptal flaps have been taken all the way up to the olfactory groove. This is now removing the septum, so this would be a septectomy up high along the anterior cranial fossa. This is now showing frontal recess over here, frontal recess and outflow over here. This here is midline. This is the septum along the anterior cranial fossa and the anterior skull base. Refining our septectomy dissection. This here is ethmoid skull base. Here's going to be anterior ethmoid artery. Posterior ethmoid artery is going to be back here. Now we're opening up the skull base. Here's the artery again. It's skeletonized, and we're moving posteriorly. This is still the rhinology team working, and this is now when the neurosurgeons enter. This is now using a drill to define the posterior limits of our dissection. This is the sphenoid sinus right here, so we're getting closer to tuberculum sella. This is opening the anterior cranial fossa. This is dura. This is removing some of the bone around the anterior cranial fossa, and then this is meningioma on dura right here, and we're dissecting that plane. Here you can see the brain with meningioma and dissecting the meningioma off the brain. This is the gross specimen right before it comes out. This is our specimen with measurements. And this represents our surgical defect. So it's an over 2 centimeter defect in width and about 3 centimeters in vertical height. So we have surgicel along the brain. This is tensor fascia lata. We're going to do a multi-layered reconstruction. This is the idea of a gasket or a bath plug technique. So this is tensor fascia lata. It's intradural inlay to seal over the tensor fascia lata. This is now an extradural layer of tensor fascia lata, and this is debated whether you need to do this or not. And then lastly, we're going to raise our nasal septal flap up over this space. You can see pulsations now of the brain and the defect in the anterior cranial fossa. This is raising our nasal septal flap over that space. So again, it's right-sided, it's medical off the posterior septal artery, and it's being raised up along the skull base. Frontal recess, all are surgical defect. So that was a benign case. However, the principles can be applied to those that are malignant. So overall, the principles that we talked about are the idea versus segmental versus piecemeal. We're going to debulk our tumor up front. We're going to trap excised tumor for pathologic analysis. And the key to this is really trying to identify where is this tumor originating from. Multi-layered reconstructions are certainly mandatory. So complications that can exist with this type of procedure we'll briefly talk a few of these. When we talked about the idea of open approaches, or open anterior craniofacial resection, historically it's been said that it's approximately 20 to 30%. Those in endoscopic approaches in the range of 5 to 10%. Of all the complications, CSF leak by far is the most common. And then complications that related to that could include pneumocephalus, meningitis, cerebritis, seizures, etc. So what do we think about complications as it relates to open versus endoscopic approaches? This is a paper from Peter Nicolai. He's a rhinologist in Italy, and he's written very extensively on skull-based tumors. As you can see here, he had 184 patients. The CEA group are the open approaches, the EEA group are the endoscopic approaches. Overall, he had a 6% complication rate in an endoscopic approach and a 16% in an open approach. Of these, most common, CSF leak. So what we can see is that the complication rates are fairly low. When they do occur, they're usually CSF leaks and less likely to be meningitis or brain abscess. This is a paper from Jeff Su looking at his complications. This was 49 patients. Again, all histologies were included. These ones were approached 73% of the time endoscopic, 27% external. You can see that his complication rate in the endoscopic group is approximately 6%, and open was 23%. So in line with the Italian group's experience as well. Interestingly, medical complications did not occur with great frequency in the endoscopic approach, whereas those that had open approaches, the medical complications were significantly higher, the order of 38% versus 8%. So there was 2 complications from the endoscopic group, and one was ptosis, and again, CSF. Here's a paper from Amin Qassam. He by far has the most experience when it relates to skull-based tumors. This was looking at his series of 800 patients. And in his series of 800 patients, he found that his CSF leak was in the range of 3 to 20%. Interestingly, when you look to see when he introduced the idea of a nasal septal flap, his complication rate dropped to 5%. Pretty powerful, the idea of this nasal septal flap. In his multivariate analysis, the only thing that came out significant for him as a predictor of who's going to have a complication and not was age. And he found that those that were greater than 60 on odds ratio multivariate analysis had a much higher incidence and likelihood of having a complication. And that was all, any complication, as long as it did reach statistical significance. The idea of seizures has been talked historically as well, and this was a nice systematic review of 530 patients. They all underwent endoscopic endonasal skull-based surgery. Some of these did have hybrid approaches, and only 6 had seizures out of 530. That was 1.1%. And we think that the reason why seizures are uncommon in the endoscopic approach to these tumors is, one, the manipulation of the brain is less than when we approach these in the traditional open approach, and also we've become very good at managing and preventing these patients with better ideas of seizure prophylaxis and loading of support. So now we're going to move towards the outcomes, and that's really where I want to focus most of our discussion today. And we've talked briefly about the limitations in the literature, and I think it is really important to stress this because it frames our whole conversation. The data sets that we have for skull-based tumors are limited, and it's for the various reasons we mentioned previously, but it's really, I think, the major important points to stress are that the heterogeneous histologic data. Many of these papers and data sets include various histologies of various grades and of various T stages. And they get lumped together into one paper, and it's hard to tease out for a given patient how to extrapolate meaningful information from the literature, and the idea of divergent outcomes being measured. So let's look at the idea of the external anterior craniofacial resection. We said that was the gold standard. And it turns out that in the literature, the overall survival was in the range of 40 to 50%. We presented some data earlier that kind of highlighted that idea. This is showing it through other studies as well, 40 to 50%, and we know that the histologic poor performers are typically melanoma that's not. Margins matter, and we're going to show data here in just a moment to show and highlight that idea of margins as it relates to skull-based tumors. So the overall survival of these tumors, this was an international collaborative group. This was a study of 334 patients. Interestingly, adenocarcinoma squamous were equal in incidence in this series. They excluded aesthesios, and this 41% had intracranial extension, whereas 26% had dural involvement, and 9% had brain invasion. All of these were approached externally. So no hybrid approaches, no endoscopic techniques. When we look at these data, we see that their 5-year disease-specific survival is in the order of 53%. Their 5-year overall survival is 48%. So again, we're seeing those numbers between 40 and 50%. And you can see that their follow-up time was out to 10 years. How does it relate to margins? This is from the same group, same series of patients, specifically looking at the idea of margins. So again, all externally approached. Those that have negative margins, 64%. Those with positive margins, 25%. And this did reach statistical significance. So it highlights the idea that even though we've shown that these can be approached in a piecemeal manner, margins are still matter very much, and the idea of oncologic principles are still paramount. What about as it relates to histology? Again, external approaches, same series. And we can see here in these data, squames and adenos on the order of 50 to 60%. Minor salivary gland tumors do a little bit better. Melanoma fares worse. SNUC was not included in these data. So how about the endoscopic anterior pressure resection? We said Castellano described this. He subsequently popularized it. He was the first to present a series of his experience with these tumors. He had a 95% control rate, and I highlight here that it was all neoplasms. He actually had 17 cancers and 2 benign. In those that were malignant, he had a 94% control rate, but this was out to just shy of 3 years. So we're not at the 5-year mark, we're not at the 10-year mark, and he didn't present, or he hasn't published follow-up data on these patients at this point. He had a 10% complication rate with no mortality. This is a series of 49 patients from Valerie Lund. Valerie Lund is a rhinologist in the United Kingdom. She approached these all endoscopic, they were all malignant, and 76% received adjuvant therapy. In her series, histologic all-comers, overall survival was in the order of 80 to 90%. Disease-free survival slightly less, approximately 70%. Her length of stay on average was 5 days. She had no major complications. MD Anderson has recently published their series. This was a series from 1992 to 2007. This included 120 patients. 78% were approached endoscopically, 22% were approached combined. There was no significant difference between either one of these approaches, endoscopic or combined. What is not clear is if whether patients were sub-selected for combined approaches based on advanced T-stage or histologic poor performers. We can see this in tabular or graphical form, this data that we talked about. This is again looking at MD Anderson experience. This was looking at the overall survival and disease-free survival versus 5 versus 10 years. The overall survival here we see is fairly less, in the order of 40 to 50%. These were for all comers, and the disease-specific survival was much higher. When you break it down into 5 and 10 year survival based on the endoscopic experience, it was 87 to 80%, and it was 76 and 50% versus for overall survival. So again, we're seeing this trend that in endoscopic approaches, we're on the order of 70 to 80%, and a trend with external, we're on the order of 40 to 50%. This is a series from Jeff Su and Vijay Ramakrishnan. This was their series of 49 patients. Again, all histologic all-comers, all T stages. 73% were approached endoscopic. When we looked at their data set from 1 to 5 years, 96% disease-free survival, 67% in open. At 5 years, they dropped to 56%, and the endoscopic would drop to 81%. This is shown in graphical form of what we just talked about. This is again looking at Jeff Su's paper. This is overall survival. So the previous data was disease-free survival. Endoscopic, 100 to 93% over 5 years. Open, 100 to 60%. The Italians, 184 patients, 3 years follow-up. Various T stages. 50% of these patients had adjuvant therapy. 73% approached endoscopic, 27% combined. Disease-specific survival, 91% versus 59% in hybrid procedures. This was statistically significant. Again, we don't know where these patients self-selected into this category based on advanced T-stage or histology. How about by tumor type? This is an area of active ongoing research currently because of the limitations we've stated. Recent papers have come out regarding squamous cell carcinoma. I'll show you a few representative data sets for that. Adenoid cystic and SNUC. MD Anderson actually has some interesting work coming out with SNUC in terms of genotype and the management algorithm for these patients based on their genotype. Recurrence rates are important. With those patients that undergo, this is from Peter Nicolai's paper from the Italian groups. This was that 184 patient group. In his subset of recurrent patients, he had 25 recurrences in endoscopic, he had 18 in open approaches. Those that recurred by histology were most commonly related to epithelial neoplasms and then melanoma. However, if you take this in the context of how many patients there were, you can see that there were 17 recurrences in melanoma. I'm sorry, 17 patients with melanoma, 11 of them that recurred. Only 25 out of 111 with epithelial neoplasms recurred. So again, we see this kind of trend with the histologic poor performers. Melanoma and SNUC do not fare well. Here's a different group. This is University of Pennsylvania's experience. 2002 to 2010, 49 patients, all histologies. Overall recurrence rate was 14%. 73% were approached endoscopic, the remaining were approached externally. Local control, or local recurrence rates rather, 11% in endoscopic versus 31 in external. 3% for distant, 15% external. Why did they have better local control for endoscopic versus external? Again, maybe it's patient selection, perhaps it's magnified view and a better appreciation of the tumor delineation at the time of surgery. Not entirely sure. Here's a few brief slides on histology that relates to histologic subtypes. This is a squamous cell carcinoma outcomes that was recently published. So this was 34 patients. We don't know if they were all from IP or whether these were squamous de novo. This was over a 12-year period. The treatment was mixed. Some of these patients had lateral rhinotomy, other had purely endoscopic, other had a mid-face degloving. 85% of the tumors were T3, T4. Mean follow-up was just shy of 3 years. Of the endoscopic, 26% had hybrid procedures. 5-year disease-free survival, 60%. As we can see, we have many different variables and moving parts to this, and it's hard to take away meaningful information for a given patient based on these data. This is another series. This is the same group. This is now looking at the idea of margins. 5-year disease-free survival, and those with a negative margin, order of 70-80%. Overall survival in the order of 90% with a negative margin. Margins matter. Those with a positive margin had 0% overall survival or disease-free survival of 5 years. So how can we address these limitations? What can we do? How can we improve our data sets? And I think several things can be done, and one of the exciting things that can be done here is the Corsica database. And so this is a prospective registry for sinonasal cancer. You've heard of this before from Dan Beswick, who is leading this charge, and this was a grant that was obtained by Drs. Wong and Holsinger. And this patient, Natalie Cole, had sinonasal endocarcinoma carcinoma and ultimately succumbed to disease. And this database is really to preserve her legacy and her memory as it relates to her family. So this uses RedCap database technology. This will be rolling out soon. It's an ongoing project. And the idea is to capture prospectively, track demographics, quality of life, treatment methods are used, the histology, the genotypes, everything that we can on these patients to understand them in a more prospective, rigorous manner to ultimately refine how we discuss and recommend treatment for these patients. So in summary, I think that early evidence suggests that endoscopic approaches may offer comparable survival outcomes to open approaches, particularly when the resection and tumor margins are anatomically equivalent. I do not think that the evidence is here at this moment to support or advocate for endoscopic approaches in a superior manner to open approaches. I think we have the best evidence for early tumors, and those with T3 and T4 tumors are probably being self-selected to these hybrid or external approaches. And ultimately, I think we need more data to compare the outcomes for the advanced stage tumors. If endoscopic approaches can be shown to be tumor-specific and stage-specific prospective data to further validate these, and if we can show that there's oncologic equivalence, then perhaps quality of life can tease out who and what patients are better suited to endoscopic approaches versus open approaches. And I do think endoscopic approaches are the standard of care for benign tumor nowadays, and open approaches are becoming more of a historical consideration. Thank you for your time and attention, and be happy to answer any questions.